Hello friends, today we are going to learn about anatomical landmarks in mandible. Earlier we have learned anatomical landmarks in maxilla, that is in different video. If anyone haven't seen that video, you can go back and see that video first and then come back to this video. I will share the link of the video in the description also. So let's continue with anatomical landmarks in mandible. So the anatomical landmarks in mandible, as there were in maxilla, in mandible also there are limiting structures, supporting structures and relief areas. We'll read about each of them one by one. First of all, let's start with limiting structures. Limiting structures, as the name defines, they determine and confine the extent of the denture. The limiting structures in mandible, 4 limiting structures are similar as that were in maxilla. Those are labial freedom, labial vestibule, buccal freedom and buccal vestibule. Now another 4 are different in mandible. These are lingual freedom, alveololingual sulcus, retromolar pad, pterygomandibular raphe. For exam purpose, you can remember these 4 are similar as they are in maxilla. Only these 4 are different in mandible. Labial freedom. So, what is labial freedom? It is a fibrous band similar to that found in the maxilla, and the muscles incisivus and orbicularis oris influence this frenum. These are the 2 muscles which influence the frenum. Unlike maxillary labial freedom, it is active. When we read in maxilla, it was passive, but in mandible, the labial freedom is active. As we can see in the diagram, this is mandible, this is frenum. Labial freedom. The mandibular labial freedom receives attachment from orbicularis oris muscle, hence it is quite sensitive and active. On opening wide open, the sulcus gets narrowed and hence the impression will be narrowest in the anterior labial region. Labial vestibule. What is labial vestibule? Labial vestibule is the space between the residual alveolar ridge and the lips. If we see, if this is our lip, this is lip and this is ridge. So the space over here, this is vestibule, and hence it is present towards lips, so it is called labial vestibule. The length and thickness of the labial flange of this denture in this space is crucial in influencing the lip support and retention. Buccal freedom. Buccal freedom overlies depressor anguli oris. The fiber of buccinator are attached to the frenum and it should be relieved to prevent displacement of the denture during the function. Buccal vestibule. Buccal vestibule extends posteriorly from buccal freedom till retromolar region, and it is bound to the residual alveolar ridge on one side and buccinator on other side. Buccal vestibule space is influenced by the action of masseter. When the masseter contracts, it pushes inward against the buccinator, producing a bulge into the mouth, and this bulge can be recorded only when the masseter contracts. It is reproduced as a notch in the denture flange called masseteric notch. This is very important. Sometimes this question is asked in entrance exams, what is mesenteric notch. Lingual Freedom. So, lingual freedom. The height and width of the frenum varies considerably. Relief should be provided in the anterior portion of the lingual flange. This anterior portion of the lingual flange is called sublingual crescent area. A high lingual frenum is called the tongue tie, which is again important. What is tongue tie? When the lingual frenum is very high, its attachment is high, it is called tongue tie. It should be corrected if it affects the stability of the denture. If it is not affecting the stability, if it is not hindering with the denture, then there is no need to remove it. If it is hindering and affecting the stability of the denture, then it have to be corrected. Alveololingual sulcus. Alveololingual sulcus. It extends from lingual frenum to the retromyelohyoid curtain. It is considered in three regions, mainly anterior region, middle region and posterior region. Anterior region. Anterior region extends from lingual frenum to pre-myelohyoid fossa, where the myelohyoid curve below the sulcus. We can see the same in the diagram. See, if this is a mandible, this region, this is called anterior region. This is anterior region of alveololingual sulcus. The flange will be shorter anteriorly and it should touch the mucosa of the floor of the mouth when tip of the tongue touches the upper incisors. Middle region. Middle region extends from pre-myelohyoid fossa to the distal end of the mylohyoid ridge. We can see same in the diagram. This was the mandible. This is fossa. This area, this is called middle region of alveololingual sulcus. The middle region is shallower than the parts of the sulcus, and this is due to the prominence of the mylohyoid ridge and action of mylohyoid muscle, as I have already shown in the diagram. The lingual flange should slope medially towards the tongue, and this sloping helps in three ways. First, the tongue rests over the flange, stabilizing the denture, so it is providing stability. Second, it provides space for raising the floor of the mouth without displacing the denture. And third, the peripheral seal is maintained during the function. So, it is providing three major functions, which are stability, space and peripheral seal. Posterior region. Posterior region, the retromyelohyoid fossa is present here, and this is commonly known as lateral throat form. We can say this as lateral throat form also. Let's see in the diagram. As this is mandible, this area, this is called posterior region. This is posterior region of alveololingual sulcus. The denture flange in this region should turn laterally towards the ramus of the mandible to fill up the fossa and complete the typical S turn of the lingual flange of the lower denture. Retromyelohyoid fossa. Retromyelohyoid fossa belongs to posterior part of the alveololingual sulcus. It lies posterior to the myelohyoid muscle. As I already shown you in the diagram, see, if this is mandible, here lies the retromyelohyoid fossa. This fossa is bounded anteriorly by retromyelohyoid curtain, posterolaterally by superior constrictor of pharynx, posteromedially by palatoglossus and lateral surface of tongue, and inferiorly by submandibular gland. This you have to remember. Retromolar pad. The retromolar pad is an important structure which forms the posterior seal of the mandibular denture, and it is non-keratinized pad of tissue seen as a posterior continuation of pear-shaped pad. The pear-shaped pad is a triangular keratinized soft pad of tissue at the distal end of the ridge. It is nothing but the collection of loose connective tissues with aggregate of mucosal glands. It is bounded posteriorly by tendons of temporalis, laterally by buccinator, and medially by pterygomandibular raphe and superior constrictor muscle. So, the muscles I mentioned limits the denture extent and prevent the placement of extra pressure during the impression making. So, the denture base should extend only 1/2 to 2/3 over the retromolar pad. Pterygomandibular raphe. Pterygomandibular raphe arises from hamular process of medial pterygoid plate and gets attached to Mylohyoid ridge. Let's see in the diagram. See, if this is maxilla, this is mandible, this is pterygomandibular raphe. The raphe is tendinous insertion of two muscles. Posteromedially, superior constrictor is inserted and anterolaterally, buccinator is inserted. It is very prominent in some patients where a notch-like relief may be required on the denture. Most patients do not require any clearance. A simple, wide open visual and digital inspection is sufficient to determine the need for clearance. Now, let's move on to supporting structures. What all are the supporting structure in mandible? These are buccal shelf area and residual alveolar ridge. Buccal shelf area. It is the area between buccal frenum and anterior border of the masseter. See in the diagram, this is mandible coronoid process. Here it is buccal shelf area. Buccal shelf area is bounded medially by crest of the ridge, distally by retromolar pad, and laterally by external oblique ridge. The width of buccal shelf area increases as alveolar resorption continues, and it has a thick submucosa overlying a cortical plate. As it lies at right angle to the occlusal forces, it serves as a primary stress bearing area. Remember this, it serves as primary stress bearing area. Residual alveolar ridge. As the name suggests, residual alveolar ridge, the ridge which is remained after extraction of teeth. Due to resorption, the mandible inclines outward and becomes progressively wider, and the maxilla resorbs upward and inward, making it smaller. So this is the difference between the maxillary ridge and mandibular alveolar ridge, which is remained after extraction of tooth. In mandible, Due to resorption, the mandible inclines outward, making it wider. The ridge becomes wider. But in maxilla, the resorption occurs upward and inward, making the maxilla smaller. This gives prognathic appearance in long-term edentulous patients. Relief areas. In mandible, there are 4 relief areas: Mylohyoid Ridge, mental foramen, Genial Tubercles, and Torus Mandibularis. Mylohyoid Ridge. Mylohyoid Ridge runs along lingual surface of the mandible. Anteriorly, the ridge lies close to the inferior border of the mandible, and posteriorly, it lies flush with the residual ridge. See, if this is mandible, this will be the ridge. Anteriorly, it is close to the inferior border, but posteriorly, it will be flushing to the residual ridge. Thin mucosa over mylohyoid ridge may get traumatized and should be relieved. Hence, the ridge is a prominent part. So, the area which will be underneath that will be an undercut. Mental foramen. Mental foramen lies between first and second premolar region. Due to ridge resorption, it may lie close to ridge. It should be relieved in these cases as pressure over the nerve produces paresthesia. See in the diagram, if this is mandible, this is mental foramen. Genial tubercles. Genial tubercles are a pair of bony tubercles found anteriorly on the lingual side of the body of the mandible. Due to resorption, it may become increasingly prominent, making denture uses difficult. Torus mandibularis. Torus mandibularis is an abnormal bony prominence found bilaterally on lingual side. It is present on both sides near the premolar region. It is covered by thin mucosa and it has to be relieved or surgically removed as decided by its size and extent. If its size is very big and is hindering the denture and affecting the stability, then it have to be removed. If it is very small and negligible in size and it is not hindering the stability of the denture, then it is left like that and the denture is modified accordingly. Thank you for watching my video. Friends, if you like my video, please subscribe my channel and ring the bell icon for latest updates.